All right. Hello, everyone. Uh, we're going to be talking today about a very interesting topic, interventional cancer pain. It will take me around 1 hour, inshallah, to finish up this presentation. First of all, we want to, explain what is meant by total pain. Okay, this is very important for your understanding of cancer pain. This term was coined by Cicely Saunders in the 70s, where she suggested that pain can be understood as having physical, psychological, social, emotional, and spiritual components. These are objectives for today. We'll start with the prevalence of cancer pain. Uh, pooled data from around 52 articles showed that pain was prevalent in cancer patients. 64% in patients with metastatic or advanced stage disease, 59% in patients on anti cancer treatment, and even 33% in patients after curative treatment. And despite the clear WHO recommendations, cancer pain is still a major problem. The good news is, uh, pharmacological treatment can be effective in around 90% of patients. Now, this means that we're going to have like 10% of the patients, we're going to have difficulty treating their pain. And this is why we have these multidisciplinary techniques, psychological, physical therapy, interventions, surgery. But the good news is, we can actually take care of 90% of these patients with giving them the appropriate pain medications. This is the WHO guidelines, which was basically presented by the WHO in the 80s. Now we extended, the WHO ladder here. We're having step 4, which includes, nerve blocks, epidurals, pumps, spinal stimulators, and neurolytic blocks. Before I, get deeper here, I want to explain what is echo model. I mean, you can use this model for almost everything that you're doing in your life here. Okay, before you do any procedure or give any medication or whatever, okay, look up 4 things. First, evidence. Okay, do we have evidence for this intervention or not? Number 2, the cost. Are you able to pay for this procedure or not? Okay, or medication. I mean, whatever, right? Number 3 is the harm. How much harm this technique will cause? Okay, because this will, affect your outcome here. And lastly, but not the last, uh, is your opinion, or the patient opinion. All right, because the patient might have a different opinion. He doesn't want, a needle in his body. The patient doesn't want to take medications. He doesn't want to do this or that, or he wants this. Okay, patient is not convinced with, let us say, complementary medicine. So the opinion of the patient plays a role in determining what procedure you're going to be doing. This classification of neoplasm related pain is so important. This was put forward by a lady, her name is Dr. Foley. And I think you can apply it also in non-cancer pain. So you have six types of pain. And this pain, I always, when I explain to my fellows, I always explain to them that these are six different animals here that you're dealing with. You know, you have the acute neoplasm related pain, you have the chronic neoplasm related pain, you have treatment related pain, you have patient with a history of pre-existing pain, patients with history of drug abuse, and dying patients. Each of these are, different than the other, and your requirements of the medications that you're giving will be completely different. Okay, because we don't have enough time to go through the six of these, different types of cancer pain, we're gonna restrict ourselves to the treatment-related pain. And as you can see, we have a huge list here of treatment related pains, like, for example, post chemotherapy pain syndrome. Patients develop neuropathy, patients develop a vascular necrosis of the femoral or humeral head, patients can develop a gynecomastia from hormonal therapy for prostate cancer. Patients can have chronic post-surgical pain syndromes like post-mastectomy, post-radical neck dissection, post-thoracotomy, phantom limb pain, or even post-radiation therapy syndromes like brachial and lumbosacral plexopathies, for example. Also, radionecrosis. So we see this all the time, okay, whether in pain management or palliative care. So you need to be really well, educated about these different syndromes. And I just put the common ones. I didn't put anything that's rare here. The post-thoracotomy after nephrectomies, stump and phantom pain, post-radical neck dissection. This is a very common one, and post-mastectomy pain syndrome, which also is a very important and common one. Okay, so with the phantom limb pain, I want to just explain something important here. I mean, I'm sure all of you guys are aware about phantom limb pain. I want to say that the phantom limb pain is mainly central pain, okay? And this is why procedures are not effective in phantom limb pain. You can try different things. I mean, whatever you want, you can try. But most probably it will not work because you're dealing with a central problem. So usually the treatment ends being, anticonvulsants, and then we have something called mirror therapy, which is really a physical therapy modality, extremely useful in these patients. Phantom limb pain is different than stump pain in that, it's in the last part of the limb. And basically, we have some risk factors, such as the female gender, upper extremity amputation, presence of post and pre-amputation pain, if the patient hurts quite a bit before he gets amputated. Also, residual pain in the remaining limb, and then the time after the amputation. The longer the time, the likelihood is a phantom limb pain. This is basically the mirror therapy. You can send the patient to the physical therapist. Uh, it's super simple. Basically, you're cheating the brain or that he has a normal limb. Okay, and it for some reason works very well. And again, you know, because it is a central phenomenon. That's why it does work very well. Okay, post-mastectomy pain syndromes. Okay, these are very important pain syndromes that basically affect patients after mastectomy for more than 3 months in the chest, arm, and underarm area. Like, as we talked about phantom pain, I want to talk also about post mastectomy pain syndrome. Post mastectomy pain syndrome is mainly neuropathic. Okay. Does it have a nociceptive component? Yes, it does, but it's not the main element. The main element is neuropathic pain. And the commonest nerve that get affected is the intercostal brachial nerve. I mean, as you're all aware, intercostal brachial nerve is the lateral cutaneous branch of the first intercostal nerve. Okay, and it supplies basically the axilla, and you can access it very easily with an ultrasound. All right. Now, next to this is the neuroma pain. Also, we have a phantom breast pain, resembling exactly phantom limb pain, and the treatment is literally the same: anticonvulsants and mirror therapy. Now, to make it more sophisticated here, I counted around 8 other mechanisms for musculoskeletal sources for post-mastectomy pain syndrome. Number one is the pectoralis minor syndrome slash neurogenic thoracic outlet syndrome, cervical radiculopathy, scapulothoracic bursitis, what we call the snapping scapula syndrome. We used to have a lady, nice lady, that coming to us at KFMC that had this syndrome. She was used to work with us. Shoulder impingement syndrome, adhesive capsulitis, or what we call frozen shoulder, lymphedema, okay, from lymphangiosarcoma. We call it Stewart-Trev syndrome, myofascial pain syndrome, and lastly uh, is the nociplastic pain syndrome. Nociplastic pain syndrome is a kind of a relatively new terminology that was put by the IASP in 2017. Literally, it means, central sensation. Okay, this is the Stewart-Trav syndrome. Okay, has very poor prognosis. One of the most important nerves that can be affected also is the long thoracic nerve. Okay, um, and this can lead to winging of the scapula. And usually, if physical therapy doesn't do the job, they usually do pectoralis major transfer. Okay, we'll jump into radiation-related pain. And as you know, one of the most important complications is radiation dermatitis. But also we have different type of problems, like lumbar or brachioplexopathies, myelopathy, and osteoradionecrosis. This is basically radiation osteoradionecrosis. I see this a lot, by the way, guys. Okay, patient gets radiation, and then eventually he will start to have shoulder or hip pain, and eventually he will get a vascular necrosis. And usually these patients, if they're in a good shape, they do a replacement of them, either shoulder or hip replacement. Okay, now radiation-induced brachial plexopathy. Usually it comes in the form of upper brachial plexopathy here, with lymphedema and lack of pain, and usually has a latency period of less than 1 year. Okay, this is basically a typical picture of radiation-induced brachial plexopathy. However, if you get Horner syndrome, lower brachial plexus involvement, severe pain and hand weakness, and a latency period more than 1 year is usually more suggestive of tumor involvement. Okay, how about chemotherapy? Well, chemotherapy can also cause, a host of different complications here, like oral mucositis, osteonecrosis, herpetic pain, chemotherapy-induced peripheral neuropathy, which is really a big topic. I remember I got this picture in the exam, all right, in my pain boards. And fortunately, I saw it before, 1 day before in the internet, so I kind of captured this. So this is a basically oral mucositis. While this picture, and this is also a very common question in the exam, is osteonecrosis. This could be related to the bisphosphonates that we give for hypercalcemia of malignancy. Post-herpetic neuralgia, okay, usually this is related to reduced immunity, and it usually affects the ophthalmic nerve, all right? And this is usually a question in the exam they always ask you about. So 32% of patients, they get it in the first division of, trigeminal or the ophthalmic nerve. And then next to this is the thoracic dermatomes. Now, the most important part of the treatment is to give the antiviral, okay, in the first 48 hours, okay, such as a valacyclovir, for example. All right, procedure-related pain, like lumbar puncture, venipuncture, bone marrow aspiration. Of course, we have better techniques nowadays to help out with these procedures. Like, for example, you can put, EMLA cream. You can put good local infiltration, and give, post-procedural pain pills. Now, cancer pain in children, guys, is different than adults. Number one, it's basically leukemias, lymphomas, and sarcomas. Number two, most of these tumors are sensitive to chemoradiation. Number three, the type of pain is usually, treatment-related pain versus neoplasm-related pain in adults. All right. Cancer pain management will go through this quickly, and then we're gonna start talking about the pain interventions. All right. I don't have time to go through the 8 things that can be used for cancer pain. Number one, the CAM therapies, all right? Psychological therapies, physical therapy, pharmacological, okay, pain interventions, surgical interventions, chemotherapy, and radiation, okay? So um, we jump and get into the deep part of it, which is the pain intervention. But I want to remind you again, pharmacological treatment is the mainstay of treatment because it can help up to 90% of the patients. All right. Now we're gonna have this 10% of patients that pharmacological techniques does not control the pain. Then we're gonna have start some pain interventions here in these situations. And I just put some of the procedures here. Now, I'm sure all of you guys are surprised, by this one here, the trigger point injections. And I want to tell you something, very important here. 33% or one third of the cancer pain patients, they come to your clinic, in fact, having a myofascial pain disorder. Okay, so uh, a lot of my fellows and residents, they used to work with me, will see me do some trigger points in these patients, and they will get very good results. I mean, don't always think big. I mean, you can start with the simple things. I remember we had a case at KFMC that had you know, uh, quadratus lumbar muscle spasm. I mean, he had underlying pathology, but I don't really recall what was it, to be honest with you. But his problem was quadratus lumbar muscle spasm. It was something, he had some sort of a cancer, retroperitoneum, and he had severe, you know. So I did the injection, patient, completely, the pain completely resolved, and he didn't need to take any opioids. So always think also about, myofascial pain disorders. Okay, another procedure I want to talk about it is called the subarachnoid neurolysis. It's an old technique, but it's still available in some parts of the world. Okay, so I don't want you have to really educate yourself about it. It's simple, straightforward. You don't need a C-arm, okay? You just need to understand the anatomy behind it here. And it's mainly used for chest wall, intractable chest wall pain, okay? Of course, cancer type of pain, all right? And intractable perineal pain. All right, there's a very famous saying here for the subarachnoid neurolysis. It's easier to lay a carpet than to paper a ceiling. What does this mean? It's easier to use the phenol, which actually is hyperbaric, okay, and lay the carpet, versus using ethyl alcohol, which is actually hypobaric, and paper the ceiling. So this is, for example, the phenol, all right? And you can see you have to put the patient in a semi-supine position. And of course, you have to localize the area that you're going to be covering. Use a very small, tiny spinal needle, okay, 25 gauge, and you go there, and then you can start injecting the phenol. Uh, let us say for chest wall pain, for example, or if it's gonna be, the perineum, the patient will be sitting, as you know, for like a saddle block. All right. So they love asking this question in the exam: the positioning of the patient, in these subarachnoid neurolysis. Remember, we're aiming at the dorsal spinal root here. Okay. Now, phenol, as you know, is not irritant. Okay. Um, I think I messed up here, guys. This is alcohol here, the upper part. So don't just forget about this. Phenol is usually somewhere between 5 to 10%, and it's usually, the mechanism of action is protein denaturation here. And phenol is a local anesthetic in its own. So it doesn't irritate. You don't need to put a local with it because it will numb the nerve immediately. Now, so this one is the one for phenol. Okay, I just messed it up here. And this is for alcohol. Alcohol is hypobaric, all right? And usually we use a concentration somewhere, between 30 to 50%. And alcohol or ethyl alcohol is very irritant, okay? Sometimes this is an advantage. Like if you're gonna do, for example, the chest wall, Sometimes, if you sedate the patient well and you do it, the patient will tell you whether, you got the right spot or not. Okay, head and neck pain. I get this a lot in my clinic too, and I want to tell you, okay, head and neck pain is treated by medicine, by pharmacologic techniques. Okay, procedures is not a great idea in head and neck pain as a general concept. I mean, every once in a while you will have a good case for a procedure. Why is that? Because, of three things: the anatomic distortion, the sheltering phenomena. In other words, the tumor is covering the area where you're targeting with your needle. And lastly, the effect of these cranial nerves on swallowing and breathing. Okay? I've been asked this question several times. All right? Can we use an intrathecal drug delivery for the head and neck? Yes, you can. All right? Remember, when we do intrathecal drug delivery systems, we thread the catheter up to a T11. So it's far away, of course, from your target. But you can use, hydrophilic agents like morphine. And probably you're going to have to use higher doses of opioids. And you can cover the head and neck. It's not the perfect world, okay, for a pump, but you still can do it. Okay, one of the important syndromes is the cerebellopontine angle tumor. Okay, and this is in addition to multiple sclerosis, it's considered secondary trigeminal neuralgia. Okay, or they call it the symptomatic trigeminal, and this constitutes around 15% of the trigeminal neuralgia patients. Okay, the trigeminal ganglion block comes with its complications, and the usual question in the exam: what is the commonest complication with the trigeminal? It's the diminished corneal reflex. We're not gonna go through the techniques, guys, because this will take a very long time. Besides, I don't do the trigeminal ganglion block a lot in cancer patients. I usually, use opioids and anticonvulsants in these folks, okay? For the reasons that we mentioned earlier. Okay, however, stating this, I do more of the terminal branches. So if I find a terminal branch out of the stuff that you have here, whether supraorbital, zygomaticotemporal, zygomaticofacial, auriculotemporal, if I find a nerve that's really hot here, I will definitely inject. Okay, because this you're totally far away from everything. Okay, sometimes we use stellate ganglion blocks in patients with post-herpetic neuralgia. Okay, um, any sympathetically mediated pain in the face, you need to do a stellate ganglion block. And of course, the complications of stellate, including Horner syndrome. You can inject in the vertebral artery, you can inject in the subarachnoid space, and so forth. So, also we do it for CREPS of, complex regional pain syndrome. It's not commonly seen in the face, but it can happen. All right. So you have post-herpetic neuralgia and PrEPs. Okay, upper extremity pain. Well, this is a common problem, guys, because we have a very high incidence of breast cancer and also metastatic lung cancer. All right. The problem with upper extremity pain, if you are trying to ablate let us say the brachial plexus, you're gonna end with a functionless, upper extremity. Okay, I remember all in very old days, I used to do this crazy stuff, but nowadays I will never do something like that. Okay, like I would put phenol, for example, in the brachial plexus or this or that. But right now, okay, forget about it. Nobody will be happy if you do such thing. Especially that we have right now, different opioid, analgesics and different stuff like that. So it's really unnecessary to do it. Anyway, so but you can do suprascapular nerve block if it's a shoulder pain. You can do stellate ganglion block for sympathetic mediated pain. And sometimes you do something called percutaneous chordotomy. We're going to talk about it later on. But I want to say with there is increasing momentum of doing this percutaneous chordotomy in Europe. Actually, the main study came out of Liverpool, and I'm sure all of you guys know of Liverpool, all that. So they did like a huge number of patients for percutaneous chordotomy. So we're gonna give it some time at the end of the lecture. All right. Now, the suprascapular nerve, this is, guys, a piece of cake for you guys. You can do it the posterior approach, okay, or you can do it the anterior approach. And you can look up the techniques in, I prefer the anterior approach because, the patient is laying on his back, anatomically more stable than the one laying on his stomach here. Okay, but it's up to you, whatever you're comfortable. And all you need to do is put just a couple of cc's of phenol there and you're done. I mean, of course I do a diagnostic block first, and then I follow this with phenol. And you can, nowadays they do radio frequency. I don't see a point to do a radio frequency for patients with cancer here because this basically takes few minutes to do it. You're gonna just complicate that. But for non-cancer patients, I can understand that. Now, the consequences of this block, you will have a little bit of, difficulty in abduction of your shoulder here. Thoracic sympathetic block. Remember, if you have a sympathetic mediated pain in your upper extremity, okay, you might have a nerve, it's called the nerve of Kuhn's, coming out of, below T2 here, and you can miss it. And the stellate ganglion block will not help you a lot. So in this situation, um, especially the patient that having nerve of Kuhn's, they need a thoracic sympathetic block. Also, the thoracic sympathetic block is important for viscerally mediated pain from your chest, like lung cancer, for example. Okay, you will not be able to knock the pain by doing an intercostal block for for lung cancer. You need to do this thoracic sympathetic block, and unfortunately it has a high incidence of pneumothorax. So please, it's not a difficult procedure, but always have a backup for yourself, a surgeon or whatever, a colleague that ready to do, like a chest drain if if this patient develop pneumothorax. Just a backup, okay? And of course, after the procedure, make sure you listen well to the patient, get another X-ray, make sure you warn the patient about. All right. So it is a big complication. I mean, or important complication. I mean, it's not a. I mean, one time we had it. And I want to tell you, it wasn't a big deal. We put a chest drain, as I told you, and patient survived. Nothing happened to the patient. All right. Thoracoabdominal pain. I like to use this terminology. I like to combine the thoracic with the abdomen because it's very difficult to really separate them from each other. So for somatic pain, we use the intercostal nerve blocks. All right. And again, for the thoracic visceral pain, like lung cancer, we do the thoracic sympathetic blockade. You can do the thoracic subarachnoid neurolysis for chest work, for somatic pain. Again, remember, we talked about it early on. And celiac plexus block for upper abdominal visceral. So any pain in the upper abdomen until the junction of the transverse colon with the descending colon, this is under the care of the celiac plexus. Remember, guys, really, I know it's kind of odd, but it's very important for you to differentiate between visceral and somatic pain. I mean, this is ABC pain management. But if you're not able, you might need to really revise the difference between these types of pain. Intercostal neurolysis, by the way, during an intercostal neurolysis, it's not, it's not associated with high incidence of pneumothorax, like the thoracic sympathetic block. It's less than 0.5%. The reason is, when you go from outside, you really, to induce pneumothorax, you have to puncture the visceral pleura. I mean, most people think if I puncture the parietal pleura, I will get a pneumothorax. No, because, even if you puncture the parietal pleura, okay, by accident, you still have a closed loop. You're not introducing air inside the lung, so just be aware about this issue. You do it somewhere between 5 to 7 centimeter for midline, a patient prone position, and then you start with a diagnostic block, of course, like as usual, with local anesthetic and steroids, and then if it does work but doesn't last long, you inject phenol. I used to do a cryoablation. All right. Now, somebody might ask me about radio frequency. You can do pulsed radio frequency. Okay. Um, it's the problem with this, if you really burn the nerve, with a conventional RFA, you can develop like a hernia because the intercostal nerves are actually motor and sensory, in the same setting here. All right, this is how we do it. First, you hit the lower aspect of the rib, and then use a bent needle tip, and you can just turn it around and just get behind below the rib. It's really a super simple procedure. I've taught it to many residents and fellows, and they were doing it all the time in the ER, and for cancer patients, for anybody with rib fracture and so forth. Okay, celiac plexus block. I want to say this is one of the most effective blocks in cancer pain, with a 80% efficacy, okay, if it's done correctly. The anesthesiologists or pain interventions in general, interventionists, they do it under C-arm, posterior approach, either transaortic or, and you just, retrocrural sort of. anterocrural. All right. There are a variety of techniques. All right. And I'm going to explain to you in just a second here when to do this and when to do that. All right. Now, if you have somebody with any kind of tumor, let's just say pancreatic cancer, which is one of the most important indications, try to look up his MRI or his CT. If there is lots of distortion, guys, in the abdomen, do what we call the splanchnic nerve block. Okay, look here, please. This is the splanchnic nerve before it perforates the diaphragm. All right, because you're totally away from the organs. So the splanchnic nerve block would be the best. All right. Now, if you don't have a lot of anatomic distortion, you can proceed with the regular celiac plexus. Okay, you can do it. Uh, you know, um, what we call the intercrural, or you can do the transaortic. Okay, you go through the aorta with one needle only, and you can inject the celiac plexus. So when do I do this one and when do I don't do this one? Okay, and this is important, guys. Again, if you look up the CT or the MRI of the abdomen before the procedure, you know, uh, look it up because if the patient has an abdominal aortic aneurysm, do not do the transaortic, please. Okay, because if you do the transaortic, you can end up with a disaster, dissection of the aorta. I think this is very clear for you. All right. Now, in old days, we used to do diagnostic block in one day, and then, the alcohol or the neurolytic block in another day. Nowadays, I do it on the same setting. Okay, because a lot of these patients, very difficult for them to lay on their stomach for a long time here. So if I do it, I do the diagnostic first with the local. If patient is doing very well and the pain is gone, I follow this with the neurolytic agent. Okay, this is the celiac plexus. Now, there are a variety of other, colleagues that do the celiac plexus, like the gastroenterologist. They go through the stomach with an ultrasound, and they can, go and inject the celiac plexus, or the surgeons, if during the surgery they can inject the celiac plexus. These are the complications. Now, I want to mention that, we have simple complications that you don't have to, get super obsessed about it, like local pain, diarrhea, hypotension. All right. I remember a patient I did in the US, and this guy had diarrhea after the procedure and had orthostatic hypotension from the splanchnic vasodilatation. And he returned at the end of the day in the ER with low blood pressure. Okay, so we just gave him some fluids. And basically, you have to give fluids during the case. You give like at least 500 cc of to 1 liter of fluids. Now, the major complications, this is what is very worrisome here. The paraplegia and the dissection of the aorta, because you can actually get some alcohol around the radicular vessels, and this can do vasospasm and can cause spinal cord infarction, and you can end with the paraplegia. So you have to consent the patient on these. Okay, now if you're doing the transaortic technique, which is a technique that I like really to do it because it's a one needle technique. Okay, you don't need to go from both sides here. And again, you have to also tell the patient there's a small chance of getting a dissection of the aorta. Okay, um, we'll get into the pelvic. I like also to combine the pelvic with the perineum, okay? Because it's very difficult for me to really separate them anatomically. But, pelvic. I like to call them pelvic perineal pain. I mean, make it simple. But anyway, so we have different techniques for the pelvic pain. All of you guys are aware about the superior hypogastric, and this is again for the visceral pain. Okay, you can do the subarachnoid neurolytic block. For the perineal pain, you can do the subarachnoid neurolytic block. You can do pudendal. You can do ganglion of impar for viscerally mediated pain. And again, you have to differentiate between the somatic and the visceral. To uh, sometimes it's difficult, but in general, somatic pain, guys, is localized. Visceral pain is usually diffuse. Somatic pain is mainly, the pain is, sharp, very clear, but with this visceral pain, it's usually associated with autonomic manifestations. So there are some, uh, differences here that can tell you whether this, of course, anatomically speaking, looking at the X-ray or looking at the MRI or CT, you can see where the tumor is. You can basically say this is visceral or somatic. Okay, now what does this? I mean, I know this is a stupid thing, but I have to clarify it with you. What is a pelvis means? It's really, pelvis is anything below this line here, the intertubercular line. Okay, um, so the right iliac. Remember from old days, when we used to divide the abdomen into nine zones here. Okay, the lower zone here is the pelvis. Okay, now the pelvis again and the perineum is supplied by the superior hypogastric supplies the pelvis, and then you have the inferior hypogastric, which supplies both pelvis and perineum. All right. And then you have of course, the ganglion of impar, that's mainly for the perineal visceral, like somebody with rectal cancer, for example. Okay. As far as the somatic pain for the pelvis and the perineum comes from the lumbosacral plexus. Okay, this is the hypogastric plexus block, and by the way, it's a kind of a recent procedure that showed up in the 90s, like mid 90s. And I remember, we uh, I used to work in Chicago, and it was like when we got the article, we had a patient, that we did this procedure on her, and she did actually very well. Anyway, your tip of the needle will be basically at the junction of L5 and S1 here. All right. And again, this is for intractable visceral and pelvic cancer pain. Can you do it for non-cancer? Yes, you can do it. It's somewhat safe, or safer than the celiac at least. All right, this is remember, when you put your needle, you have to go a little bit beyond the vertebral body here. All right, so like with lumbar sympathetic block, the tip of the needle is at the edge of the vertebral body. But with this one, you go a little bit beyond, as you see here in the picture. And you have to do it from both sides because, it's bilateral. I remember when I went for my fellowship interview, pain fellowship. I mean, this hypogastric block was like, you know, uh, Still, just came out in this time because I did my fellowship in '96. So he asked me how many hypogastric plexus do we have. Okay, so basically two. I mean, celiac plexus is a one block. It's a one, plexus, but hypogastric bilateral. So you have to do it from both sides. Anyway, lower extremity pain. Um, Same like upper extremity. All right. If you ablate the plexus, you can lead to a functionless limb. And thus, we try not to. We can do this local anesthetic with the steroid blocks, and also you can try, intrathecal analgesia and percutaneous chordotomy. Sacral nerve root neurolysis. This was described early on by Bonica and the big Bonica. They used to do it, of course, blindly. Nowadays, we do it under CR. A lumbar sympathetic neurolysis. I want to just explain something. As you see here, it's just at the edge of the vertebral body. I want to say something. One of the complications of lumbar sympathetic neurolysis, and this is a very common exam question, is getting what we call genitofemoral neuralgia here. All right. This is the genitofemoral, guys. It runs over the psoas major, and it gets two branches here, the femoral and the genital branch. So sometimes the pain radiates to the genitals, and sometimes it's in the upper part of the limb. Okay, pudendal nerve block. This is one of my favorite blocks because it's super simple and extremely useful. I will never forget this patient I had that had penile cancer, metastatic penile cancer. It was horrible. Okay, just imagine, how painful it would be. So we did this pudendal block, and it worked fantastic. Of course, the pudendal here, we do it under C-arm, and we don't do it the old-fashioned type of deal where you go it transrectal and I mean, we do it at the ischial spine, the tip of the ischial spine here. Okay, this is it. This is the tip of the ischial spine. All right, extremely simple. As some of the indications and complications of pudendal block. We use pudendal blocks for other, pain conditions like, pudendal neuralgia, proctalgia fugax, vaginismus, anorectal pain, second stage of labor. For you guys, maybe you will never see this, but like when I did my OB, GYN kind of things, yeah, like 30 or 40 years ago, I don't remember. But we used to do a lot of these pudendal blocks, okay, for second stage, because we didn't do a lot of epidurals at this time. All right, ganglion of impulse, extremely important, block for intractable, again, visceral and perineal pain, such as, for example, rectal pain, for example. Okay, and in all days, this technique came out same time with the hypogastric. The same author did both of them. He was the head of, the pain department in Mexico. Anyway, he did it, from the lower aspect of the coccyx, from here. And of course, this had a high risk of causing rectal injury. And I remember my mentor he was a genius guy. So I showed him this procedure, the oracle, and he said, no, 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 this is crap. We're gonna probably do better than him. So he went and did it through the sacrococcygeal junction. All right, and this is right now is the standard right now of the procedures that we're doing here. And again here, you go through the sacrococcygeal junction. You get what we call the comma sign, and you can follow this with phenol if it's cancer patient. Okay, we'll jump into neurosurgical interventions. All right. Now, I want you to understand this is not necessarily, you're not going to be doing a lot of these procedures, okay? But some of them can be done by the anesthesiologist, and we're going to talk about. So basically, you can divide neurosurgical interventions into three categories. Number one, anatomic, where you just remove the tumor. I mean, as simple as such. Or augmentative, okay, such as dorsal column stimulation or intrathecal pump, vertebroplasty, kyphoplasty. These are called augmentative procedure. And lastly, are basically the ablative procedures, all right, like DRES, all right, midline myelotomy, percutaneous chordotomy, and cingulotomy. In fact, actually, the only procedure from the you're gonna do are the augmentative. This is as an intervention pain physician. Possibly, do these pumps, stimulators, vertebroplasties. All of this is under our umbrella. As far as the ablative procedure, the only one is the percutaneous chordotomy. Okay, we'll start with some of these, augmentative, the intrathecal pumps. Uh, we have three types of pumps. Okay, you have the externalized system. They call it the DUPAN. Not a lot of folks are using it nowadays, guys. All right, I just want to tell you. I remember a long time ago, we got the rep, and it's like it used to cost like $1,000 the kit. Uh, but this one is reasonable and still used in a lot of countries, which is the partial externalized system, the portacath. All right, exactly like the portacath that you use for delivering chemotherapy, but you stick it in the epidural space. Okay. Now, I want to say that um, uh, this one is mainly for patient that has like lifespan less than 3 months. All right. But if you have somebody that probably gonna live 6 months or more, you can put a fully implanted intrathecal delivery system, the programmable system. All right. And there are multiple companies doing this. Uh, the most famous one is the Medtronic, uh, Porticath, the Dupan, forget about it. It's really not a lot of people doing this stuff. But the Porticath is really a nice one. Unfortunately, you have to hang the local and the aesthetic or the morphine or whatever, continuously from outside. So the patient has to come to you maybe every 2 3 days to fill up the pump, put a new infusion and so forth. Or the nurse can go to him at home and she can hook it up for him. They use like a needle called the Huber needle, okay, where they puncture the septum and it's connected to, the bag, exactly like you're doing chemotherapy, but in the epidural space. And you use the same medication, morphine and whatever you have, fentanyl. Okay, this is the programmable pump. And I want to say that this is actually right now the mainstay of treatment in intractable cancer pain in Europe and United States. And they even favor it on, you know, stuff like, doing these neurolytic blocks because of the medical legal liabilities of getting like paraplegia, for example. All right. Now, the tip of the catheter is thread to T11. Remember this number. Okay, we can discuss later on why, but it's a T11. All right, because of the CSF